Welcome back. Now we will be starting session 2, the role of prophylaxis pre-exposition in the reducing of stigma and discrimination. I would like to invite the first speaker, Bruce Agins. He will be presenting on stigma reduction through improving health system for people living with HIV and key populations. Bruce Agins is an infectious disease physician and public health professional with over 25 years of experience in design, oversight, and evaluation of government-led health care quality management programs. Dr. Agins is currently professor of infectious diseases epidemiology in the Institute for Global Health Science at the University of California, San Francisco, where he continues to direct Health Equal.
Good afternoon. I'd like to thank the organizers for inviting me to present today on our work focusing on stigma reduction in healthcare facilities. As we know, stigma and discrimination still have terrible consequences. As described in this UNAIDS report, we know that the very people who are meant to be protecting, supporting, and healing people living with HIV often discriminate against the people who should be in their care, denying access to critical HIV services, resulting in more HIV infections and more deaths. WHO has called for a fourth 90, underscoring this issue, so that fourth 90 would ensure that 90% of people with viral load suppression have good health-related quality of life. And here's a graphic describing that from the Lazarus paper that described the fourth 90. We also like to look at stigma and discrimination through the quality lens, and that means focusing on equity, which is one of its key domains. Equity is defined as providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, socioeconomic status, and medical condition. And as the Lancet Global Health Commission on High Quality Health Systems has reported, quality of care is worst for vulnerable groups, including the poor, the less educated, adolescents, and those with stigmatized conditions. So people with HIV and from key populations who are often at the edges of the health system. From the quality lens, we like to think of quality as both technical and experiential. On the technical side, that means focusing on whether care is effective and safe, which is how providers often perceive care. But equally important is the experiential side of quality, which is how patients think of their care. And that means that care is equitable and people-centered. And so through our initiative, we aim to apply quality improvement methods through a multi-country learning network involving Cambodia, Laos, PDR, Thailand, and Vietnam to support ministries of health to implement quality improvement learning networks focusing on reduction of stigma in health facilities by testing changes, instituting routine measurement, and fostering peer learning. This in turn would encourage implementation of policy initiatives to encourage stigma reduction in healthcare facilities, empower patient groups to take an active role in quality of care decision-making at all levels of the health system, and to exchange knowledge between the countries that advances learning about how stigma can be reduced and improve the lives of people living with HIV in Southeast Asia and globally. Our focus, initially funded through PEPFAR, it was at the multi-country level, where we brought countries and still bring countries together to share their experiences and their data. The countries themselves then foster quality improvement learning networks, engaging sites to apply QI methods to stigma reduction, and then the sites themselves routinely measure and test changes to improve stigma reduction and in their facilities, and that information is then shared back up at the national level and in turn at the multi-country network level. So in addition to using clinical performance data, which is the common set of metrics in quality improvement, in this network, we also use healthcare provider surveys and patient feedback, uniting these streams of data to give us a snapshot of the quality of care related to stigma reduction, which we then hope will lead to better outcomes. To look at healthcare worker attitudes, we used a survey developed by Laura Nyblade and the Health Policy Project, which has been validated in several countries and adapted for use in Southeast Asia as well. This is described in the article by Dr. Krinkrai Srithanavibunchai and can be referenced. Laura Nyblade has developed a schematic in which we identify immediately actionable drivers, including fear of transmission, awareness of stigma, attitudes, and the institutional environment, which in turn can lead to different kinds of stigma, whether it's experienced stigma, anticipated stigma, perceived stigma, and in turn the avoidance of care or harassment or refusal to treat. And that, of course, then leads to compromise in our clinical outcomes in the care cascade and viral suppression, as well as, I mentioned earlier, health-related quality of life. So in the survey, questions focus on those domains that I just highlighted. So questions address fear of transmission, willingness to treat, observed and secondary stigma, policies, and a special module focusing on attitudes about pregnant women living with HIV. The survey itself has 51 items, which we knew were more than could be addressed in routine use and quality programs. And so the network prioritized 8 questions. And I won't read these in detail, but you can see that they involve questions related to all 4 of those domains in terms of attitudes and observed behaviors, policies, and fear of transmission. Here's an example of data from Thailand, where after implementing changes across the 48 health facilities that were participating, there were significant reductions observed in the domains surveyed in the initiative. Similarly, in Lao PDR, reductions were also observed. The same is true in the other countries. I won't go through examples for all of them. Across the network, through February 2020, we've convened 7 multi-country network meetings with 83 facilities implementing quality improvement activities across 29 provinces in the 4 countries. Over 17,000 healthcare workers have completed assessments, and we still see a significant issue, although we have seen improvement. Notably, as of September 2019, we've seen a reduction from 51% to 40% of healthcare workers disagreeing that pregnant women living with HIV should be allowed to have babies. And we've seen a drop from 15% to 13.5% of observations of colleagues providing poor quality of care to people with HIV. The network has been transitioned from PEPFAR funding to support from Gilead and ViiV. So when we apply quality improvement to stigma reduction in the facilities, the teams meet to identify root causes of the problem. And you see some of these centered around a fishbone, which is the name of the tool that is used commonly in root cause analysis, and where causes are identified about staff making me wait, talking badly about me, gossiping about me, that staff may avoid touching me, they may deny me care or use double gloves. And to address these types of concerns in the facility, a number of different interventions have been tested. And these include, for example, redesign of clinic flow and improved signage, a reduction of waiting times, use of peer navigators to make the care delivery system friendlier, having better education in the facility, such as having special stigma rounds for providers, the routine measurement of both provider and patient of attitudes and experience, and convening separate committees just to focus on stigma reduction and implementing codes of conduct as routine policies that champion a stigma-free environment. We've showcased some of these examples as best practices in spotlights, which are available on the web. And I'd like to turn now to talk about patient experience and how that is captured in the network. We have the participating ministries of health choose their own methodology for routine solicitation of patient feedback. And examples of methods include surveys, exit interviews, patient forums, storytelling, comment boxes, and consumer advisory boards. And like we did with the provider questions, the network identified 8 common questions to measure patient experience. These are listed here on the slide. They're about whether the clinic is welcoming and friendly, whether one was treated with respect, whether privacy and confidentiality was observed, and whether there was stigma or discrimination experienced in the visit, among the 7 questions. In Lao, in addition to asking the questions routinely at the visits, they collect feedback in comment boxes and look at them routinely and then identify areas from those comments as priorities for their quality improvement work. And this is described in more detail in the spotlight about Champasak Hospital. One strategy in Vietnam was to develop consumer advisory boards. And in Binh Duong province, they adopted consumer advisory boards as a standard of care and has adopted it as what they call a decision for establishing the CABs in healthcare facilities. The CAB discusses improving quality with the faculty. They provide feedback through a hotline, and patients provide feedback to the CAB through a hotline, through comment boxes and exit interviews. And again, those project priorities are addressed through the quality improvement process and then discussed back with the facility staff. So for example, in Binh Duong, they were able to expand access to the clinic since patients complained that it was not frequent enough, and they focused more on assuring privacy and confidentiality of services. We've also included questions to address clinical literacy, since empowerment is also a key strategy for reducing stigma. And these questions are very straightforward about asking patients if they know their antiretroviral therapy regimen, when they're due for a viral load test, and if they're suppressed. And an example of results from one country show that we have a long way to go to improve patient literacy in our work. And this can also be addressed through quality improvement interventions. Finally, I wanted to address sustainability of this work, because our goal is that stigma reduction will be included as a routine component of quality activities. And I want to describe the example in Songkhla province in Thailand. So they started off with implementing the work in 2 pilot hospitals as part of their national program. But the leadership was so committed to this work that they wanted to expand. And so the 2 facilities, together with provincial leaders, presented the work to other hospitals, and then 6 additional hospitals joined the initiative. And they've made changes across the system in Songkhla province, including canceling of special codes that identify people with HIV, facility-wide training of all personnel about stigma, including information specifically about HIV and infection control training, and including stigma reduction quality improvement champions into their quality teams. The network meets about 3 to 4 times each year. There is informal networking between country teams. We provide technical support periodically to each country. We also engage experts and others working in the field to participate and share their work at network meetings. Country-to-country partnerships have been fostered to share training curricula, methods, and models. And as you've seen, best practices have been identified and disseminated through spotlights. That said, there are a number of challenges that this work faces. And at the microsystem level, that includes the methodological and logistical challenges associated with routine data collection and analysis of patient experience, since routinely health facilities are not accustomed to including qualitative data in their QI work. Operationalizing how QI concepts and methods can be applied to survey data and qualitative data. Disaggregating clinical performance data by key populations. And I'm sorry to report that this is in its infancy in most of the countries, but it's an important priority for us to really understand if there are disparities in clinical performance across different groups. Routine involvement of patients and consumers in quality improvement activities and overcoming some of the hierarchical boundaries between providers and consumers, and understanding the experience of patients who do not return to clinic because of stigma and discrimination, since this work focuses on patients who are receiving care in the facility. At the macro system level, there are challenges with coordinating the stigma and discrimination reduction initiative with the quality management units within HIV programs, with integrating these activities within the larger national quality programs, establishing attribution of interventions to outcomes, of using multiple data sources for national planning to achieve maximal benefit for patients, understanding the experience of people who don't engage in care at all. And in particular, I'd like to call out the involvement of civil society in programs to reduce stigma reduction in healthcare facilities. It's really important that the distinct activities in which monitoring is occurring in the community are brought together with those in the health facility so that the information that is coming from the community can be addressed in the activities at the health facility. And on a positive note, there are a number of these initiatives underway, such as the Stigma Index, Community Scorecard, and other community monitoring activities, but they often don't tend to link back up with specifics to where problems occur. And so at the national level and the policy level, we really want to bring these activities together. I'm proud to say that we have successes in this initiative. There's been active engagement and cross-country learning with participating ministries of health through the network. Malaysia and the Philippines have now joined the network, and we are in partnership and co-management with UNAIDS Western Pacific Office. The ministries are coordinating with implementing partners and civil society organizations, and we include representatives in the network meetings, and both Malaysia and Philippines are actively engaging civil society organizations right from the beginning of their work. We've seen integration of data from both patients and healthcare workers into routine quality improvement activities, as well as those to assess patient experience and treatment literacy through common indicators. And across the facilities, we've seen 27 strategies that have been tested to address those 4 immediately actionable drivers that I mentioned in the beginning of the talk, which has led to the development of evidence-informed interventions to reduce stigma in healthcare facilities. We've definitely developed a consensus that HIV-related stigma and discrimination in healthcare facilities is actionable through organizational and system-level changes, and it can be reduced. So I want to thank you for your attention, closing with some snapshots of network meetings. A shout out to Thailand, which has embraced this work at a large scale. You can read more about this initiative in the publication that is on the screen. And I would again like to disclose that this work has been supported through the PEPFAR initiative and now through funding from Gilead and ViiV, and in particular to acknowledge those who've contributed to this work. It has definitely taken a village, and a shout out to all those folks that have contributed to the work. So thank you very much for your time and attention.